Yeah, so here we are talking about knee replacement, how to get ready for it, and finding out what you need to do to get ready for it, and then when you have it, what are you going to do after? And let you explain some things so you can your expectations. You'll know what to expect when you go through this. So let's go ahead and go to the introductory slide. So just a little bit about myself. Been doing this for 28 years now. So it's been interesting watching all the different changes of the different types of knee replacements, the different procedures, and watching how people recover and some of the things that bring them to this. I got my doctorate out of Western University of Health Sciences. That's in Pomona. There's two types of doctorates now. There's the PhD doctorate, which is for research, and then there's a clinical doctorate, which all of your PTs now, the entry levels, they're all doctorates. So the clinical doctorate is for field work, the PhD is for research. So I was able to go back and do that. That was exciting. For the board certified specialty, some of us put a lot of our effort into orthopedics, and that's what I've done with my career. I had a wonderful time teaching over at Western, helping out the new PTs coming up, give them some good education and experience there. And then I've been at Eisenhower for most of my career. I only went away for 3 years for private practice, and then I came back to the hospital, and I've been enjoying it there. Our objectives for tonight, let's go ahead and go to the next slide. We're going to discuss the functional loss, what it means to your quality of life. So when you're getting osteoarthritis, what that's doing to you, you already know. And then some of this is why it leads to total joint replacement. We're going to present the concepts of why someone may need the total knee replacement. We're going to look at the anatomy and the function pre and post total knee replacement. What's it like before? What's it like after? We want to take a look at a little overview of the surgery. I do have some surgical slides, but I'm going to warn you before I show them. Some people, they don't like to see that. And for some people, it's just really interesting on how it's done. We want to present the prehab and the post-rehab. So prehab is what you do before, what can you do to get ready, and then post-op rehab is what happens after. So we're going to talk about that and the interventions we're going to do and the outcomes. And then present possible placement options for post-rehab, what happens to you after. Some people can go right home, other people need to go to skilled nursing, things like that, acute rehab centers. And then present possible outcomes after surgery, what happens after. There's so many different ways that some of these come out, and just to give you some scenarios on what to expect, and hopefully that'll be helpful with your decision making. Go ahead to the next slide. So what we're looking at here, why would you need a total knee replacement? So for some people, they have a history of trauma to the knee. So you've been in a car accident, you had a nasty fall, and the way it damaged your knee, the joint's no longer viable. So then they need to do that. My youngest one, he was a football player. The knee damage he had in the game was so bad, he had a knee replacement at 24. So that's way too young. It's rare. You don't ever want to do that because you need revisions every 20 to 30 years. So you can imagine if he lives to 80, he's going to have a couple of revisions before, as his life goes on. So other active individuals, you'll see that people have been very active, runners, marathon runners, triathletes, some of these century runs, racquetball, tennis, hiking, just highly active people. And basically what happened is they wore down the cartilage beds in their knees, and that's what brought them to that. We'll show you some x-rays on what that is. You also have people that have been living very comfortable sedentary lives. They haven't been beating up their knees at all, and they have sedentary jobs, and they're sedentary at home, and they really don't challenge that. You didn't wear it out, but it wore out anyway. So the thing is, some people beat themselves up. I shouldn't have wore it out, and I wasn't active enough. Guess what? Both of you are going to wear out as you get older. So you don't have to beat yourself up. If it's going to happen, it's going to happen. It wasn't your fault. It's just one of these facts of life. You have a disease process that advances degeneration at a faster rate. Those are things that are rheumatoid arthritis, lupus, some of these conditions where it attacks your connective tissue, and then what happens is it just ages faster. So again, when you have those disease processes, like there's JRA, juvenile rheumatoid arthritis. Some people get rheumatoid arthritis in their teens, and they end up getting joint replacement if they have much destruction there. The bottom line, knee degeneration, it just doesn't discriminate. Like I said, anybody can get it. No class, no lifestyle, whatever. If it's going to happen, it's going to happen. And then there's many variables that'll affect the rate at which you degenerate. So you just have to look at each individual as a custom scenario, and then you figure out what to do to help solve the problems. Go to the next slide. So why do you want a joint replacement? A lot of people say, they want to be pain-free. You want to continue to live an active lifestyle. You're not able to move as well, so you want that knee fixed. You want to be able to get in and out of bed and ambulate around the house without pain. Some people, they're, especially in the time of COVID, right? Where sometimes our environment we get out to, it's really just in the home, and we're having trouble with that because of the knee. You want to be able to run errands, be able to get out to a restaurant, local event, without dreading how long it will take because your knee's hurting. So you know who you are, right? You get out of the car and you're going, okay, how far is it to that table? Because my knee can handle this many steps before I'm in agony. So you may do better with replacing that knee than trying to live with it. You want to be able to play golf, tennis, or pickleball. Those are really common things I get with patients here. A lot of stop starts with pickleball, and you notice with the worn out knee how much it can bite inside that knee when you're trying to change direction really quickly. Playing golf, it's if you're a right-handed golfer and your left leg is the one that does a lot of twisting as you follow through, well, that twists your knee a little bit. So if you don't have a knee problem, you don't notice it. If you have loss of cartilage, you notice it. So then you notice you're moving your foot to different positions to try to get through that golf swing. And then the tennis, like pickleball, as you know, a lot of stop starts. So you may not be able to tolerate that anymore. Although when I skipped there, some of my patients, one of them noticed they had degenerative knee. They didn't want to get a joint replacement. They went to San Diego Zoo with their family. And then they found out that they could walk so far with the younger kids, and then they needed a wheelchair because they weren't going to make it for the rest of the day. So embarrassed by that, they wanted to be able to function, to go do these family events and things like that without having to resort to that. And then you want to be able to travel and do activities or sightsee without being limited. So, people that are traveling to Europe and whatnot, and you're dealing with cobblestones, maybe a lot of stairs, depending if you're going to the castles or the churches or things like that. You want your knee to be able to function to do those things. And this is some of the reasons why you might need the knee replacement. Going to the next slide. So the reasons people get knee surgery or knee replacement too soon. A surgeon may have told you that your knee's so degenerative, you'll need a knee replacement in 5 years. So then being a proactive person, you say, well, if I'm going to need it in 5 years, I'll just get it right now. That can cause some problems, which we'll talk about. You're about to retire, and it'll be cheaper for you to get the knee replacement while you're working you have the health insurance under your employer. So then your knee's not really bugging you, but again, you've been told that it's degenerative, you're probably going to need one. So then you go ahead and get it when it's not really bugging you. You're younger and you feel that you have the stamina to tolerate the surgery or recovery. So there is a little bit of validity to that. It's like, how healthy am I? And if I need a procedure, it's really better to do it now, because as I get older, if I decline in health, I may not be able to tolerate going on the OR table. Those are some things to think about. And then your expectations are, why wait? I'm getting a new knee, which will fix everything. Sometimes expectations are really high for that. So then you end up thinking, when should you get one? And these are some of the, again, what I'm sharing with you is experiences I've had with patients, and why they got one or why some of them got them too soon. And sometimes the outcomes weren't favorable. Most of them are favorable, but just add information for you to help you with decision making. So if the pain is really severe when you're getting up out of bed and you're dreading walking to the restroom because of that pain, that's a good time to get it, because that pain level is so high. With some of the other examples in the previous slide, getting them too soon, I had a patient or a few patients where they didn't really have symptoms, but the x-ray showed their knee was degenerating. And we're going to look at some x-rays to show you what that is. But they didn't really have symptoms. Their knees didn't hurt. So when they got told they may need a joint replacement and they're being proactive, you got to remember that when you go to surgery, they're cutting off part of the bone. So it's like a partial amputation, and then they're adding metal. So when you do that, if your knee was not really bothered and not in pain, when you wake up from having a knee replacement, now your body's in shock. Like, what did you do? I wasn't hurting before. Now I have a foreign substance inside my body, and there's all these changes. So some of the patients I've had, they've had post-op knee pain that didn't resolve after having knee replacement. And these are just assumptions on my part, but these are stories, again, just to share with you that it seems like if you didn't really have much symptoms going in, sometimes the body's reaction to the violence of having had the knee replacement, it created pain. They had irritation from the metal. Now, patients on the other end that have severe pain going in, the body's going, I got to reject this knee because you can't walk on it. So then when your pain's severe and you're saying to the doctor, okay, I can't take it anymore, then you go in. Now you start walking on your knee and the arthritis isn't there anymore. It seems that the body's more accepting of it and goes, oh my God, thanks for getting rid of that knee. And now I feel so much better with the total knee replacement. So these are not guaranteed for each patient. It's not an ironclad thing that happens to people that don't have symptoms. Some people have these knees that are structurally unsound and they're falling apart that way, but they really don't hurt. And they do better because they're now more stable. So again, these are just stories to share with you, like where I wouldn't jump to a knee too soon. If my knee was feeling good, I would probably wait until it was feeling really bad before I jumped into that. So another reason you would get it, you're fine when you're sitting, but getting from sitting to standing provokes severe knee pain or it buckles on you. Your knee pain increases with running basic errands. You can't go to Walgreens or CVS or whatever. You can't get through Vaughn's, the grocery store or whatever. And you're just dreading it. Your knee gives way uncontrollably when walking or standing with a cane or walker. So what that is you might be walking around, and as you take a step, your knee just buckles and collapses. And you don't hit the floor, but you recover it, but your knee just buckled, and then because of pain, and then you catch yourself and you stand back up, and you didn't have your fall, hopefully. And when you get giving way like that, that's structurally, that's not going to get better. So then some people need to have their joint replacement for that. You feel off balance with basic ambulation and have increased difficulty ascending or descending stairs or curves. So you'll notice some of you with some severe knee arthritis, you notice coming down a hill or down a step, you don't like putting weight on that leg because the higher the muscle has to contract hard enough to lower you to the ground. And the harder the muscle contracts, it pushes the two bones together. And if there's no cartilage there, that's why it hurts, because cartilage structurally has no nervous system. So if you opened up a knee and you took a knife and you stabbed it in someone's cartilage, they would look at you and go, I don't feel that, because there's no nerves in cartilage. Bone has nerves in it. If you break a bone, you scream. So when the cartilage bed wears away and the bone rubs into the bone going downstairs or upstairs or getting out of a chair, that's why it hurts, because you're grinding that bone into the bone. So when that's starting to happen, probably time for a joint replacement. And then if you're off balance, some people wait too long when they get the giving way. So they need a joint replacement, but that comes after the hip surgery because they fell and broke their hip. So if you notice that you're getting giving way and you're having trouble controlling your balance, you might want to solve that problem before you have a catastrophic event from knee buckling. So, and remember, when you're talking to a PT, these are the people I see. So again, these are just stories that I've gone through, just sharing with you how to prevent things and avoid things. And, I'm hoping all of you are all okay right now. Stay that way. Another reason to get them, you're taking a lot of anti-inflammatories or NSAIDs, the non-steroidal anti-inflammatory drugs is what that is. You're taking them daily to manage pain, and it's not helping as much as it did before. And then you're getting cortisone injections, and those are failing. So that tells you it's probably time to get a knee replacement. So going to the next slide. How does the knee work? Well, it's complicated. So what you're looking at there is a biomechanical diagram to show you all the different force vectors that go through when you bend and straighten your knee. We don't need to go through all that. Go on to the next slide. So when you look at patella femoral articulation, that's between your kneecap and your upper leg, which is your femur. And we're going to see an x-ray that shows you what patella femoral joint looks like. And the thing there is that when it's talking about here, transmitting tensile forces generated by the quadriceps to the patellar tendon, the muscle on the front of your leg is called the quadriceps, and the patella is your kneecap. So when that muscle contracts, it puts a lot of force through it. And what it's showing you here on the biomechanical explanation, the patellofemoral joint force reaction is up to 7 times the body weight with squatting. So when do we squat? Getting on and off the toilet. So if you notice that you're having a lot of problems getting in and out of a chair because your knee really hurts, you're putting 7 times your body weight through your kneecap to pull that off. 2 to 3 times your body weight when you're coming down the stairs. So going to the next slide. And then, yeah, so looking at just other graphs, I'm trying to figure out, you know, how you read this one is with walking, the force is 850 newtons. What's a newton? 1 newton is the weight of a medium-sized apple, because remember Newton and gravity, the apple fell on his head. Yeah, so that's how you figure out 1 medium-sized apple is the weight of 1 newton. So 850 medium-sized apples is the force that goes through when you're walking. To make it simpler though, it's about half your body weight, or about 100 pounds of force. But then you go to the bottom when you do deep squatting, which is what power lifters do when they drop their butt all the way down to the ground to lift a heavy weight. That's up to 20 times body weight. 15,000 medium-sized apples, or 4,000 pounds of pressure. You're not lifting 4,000 pounds, but that is the force that goes through that. So it's a very interesting structure on what it can perform. Go to the next slide. So that's between the kneecap and the femur. So when you're talking about tibiofemoral, that's between your shin bone on the bottom and the thigh bone on the top. So the thigh bone again is the femur, and the one that your shin is that's your tibia. So when you say tibiofemoral, you're talking about those two coming together, making a joint. And then again, showing you that, you know, 3 times your body weight with walking, 4 times your body weight with climbing. And then in the range of motion, 3 degrees of hyperextension. So when you're looking at range of motion of a knee, the knee doesn't go totally straight. It actually goes a little farther than straight. And then when you bend your knee, that's it goes up to about 155 degrees on some people. So not only are you carrying a lot of force, but you also have a range of motion that you need to do certain things. So when we talk about getting a knee replacement, getting scar tissue, if you want to be able to ride a bike, for example, you need 115 degrees of knee flexion, bending your knee, to be able to get around that circle on the bike. So these things will be important to you for, you know, why you would get a knee replacement and function you want after getting knee replacement. Go on to the next slide. So this is a little graph regarding walking speed and function, and what kind of placement you would have depending on how fast you go. So I'm not going to break this down too much to get into the weeds, but what it's showing you is on the lower ends of speed, you would likely be hospitalized or be dependent on a caregiver. When you have higher speed, you can walk across a crosswalk when the light turns green and says walk. Some people walk so slow they can't get across the street because their walking speed's too slow. So depending on things you want to do, like if you're touring Europe or something like that, you need to be able to walk. You can, when you're working with your therapist, you're figuring out, you know, what's your gait speed, what's your walking speed, and how do we train to get that back to increase your performance so you have a higher level of function. So walking speed is important regarding that. So going to knee anatomy, the next slide. So this is the tibiofemoral joint where the arrows are pointing. If you look at the one on the right, you can see the nice clear space, that black space, that's your cartilage, if you have it. The bone is what comes up white. So bone's the, you know, the hard bony structure. So if you look at the knee on the left, where it says bone on bone arthritis, where's the black space? It's gone because the cartilage has worn down to enough. There's no more cartilage there. So remember, cartilage has no nervous system, so it doesn't signal pain. Bone, if you fracture it, it hurts. So bone, when it rubs into bone under pressure, and remember the forces that we just talked about, how much body weight force you're putting through, how many newtons of force you're putting through, you're grinding that bone into bone, and that's why you're getting pain. Let's go ahead and go to the next slide. So this is a shot of looking at your knee from the top down through the kneecap. So while you're sitting in your chair, if you're looking down at your knee, that's the angle that the X-ray tech shoots to get this view. So you're looking at the space, the cartilage space between your kneecap and your femur. So you see the little notch there? It shows you the groove where the kneecap slides in. And if there's a nice bit of cartilage, it slides really nice. Going to the next slide. There you can see the cartilage is it's so thin, right? There's no space there. So if that's all worn away, that's bone again rubbing into bone between the kneecap and the femur, and that's another reason why you need the joint replacement. And then going to the next slide. Just to check, is everybody able to see the slides? Are they big enough to see, and are they just getting my face and a little picture there?
No, they're very visible, Ken.
Okay, perfect. So next slide to the joint. Yeah, no, this is good right here. Sorry, the joint replacement X-ray. So when you look at the X-ray, the question here is what's missing, and you notice that on these ones. You don't see the kneecap. So what they do on some knee replacements is there's what they call the patellar button. So they create a kneecap for you if the kneecap is really damaged and they can't do anything with it, or they resurface the bottom of it. The other thing that you lose is your ACL ligament. So if you go ahead and go to the next slide. So when you hear about football injuries a lot, is that's when you hear about the ACL injury. So the ACL is an anterior cruciate ligament, and what it does is it stops the sliding of, if you have your knees like this, it stops your bottom part, your shin, from sliding forward. So that's what the ligament stops. Now, to put the knee replacement in, you have to take out the ACL to have space to get the knee replacement in there. So you lose your ACL to do that. Now, how does that affect you? It won't, because the way the knees are designed, there's in the structure, the engineering, they have a way of compensating for that. Some people will feel a little slippage when they move certain ways, and they'll feel a little sliding in that joint, and that could be why you're feeling that, but your knee won't be unstable. So just letting you know that when they're putting things in, sometimes some things need to come out, and that's what happens there. Going to the next slide. So what you're getting is metal on plastic. It's not human tissue. So a lot of patients after knee replacement, they complain they hear clicking in their knee, and they go, something's unstable, it's making noise, and it's going, click, 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 click. How did he screw up? They go, he didn't screw up. This is what you bought. So when your knee shifts and does what it does in life, the soft tissue you have is very cushiony, so you don't hear and feel clicks. You have a nice, smooth, moving knee. When you get a total knee, you're replacing it with metal on the top, metal on the bottom with a plastic spacer. So when your knee shifts side to side, the metal will hit the plastic sometimes with certain angles, and then it goes clunk. And then you'll feel that. And it's like, you get worried, like, oh my God, something jarred loose. It's like, it didn't jar loose. That's what you bought. And that's how it sounds. Going to There's a lot of different designs now. So if you're a highly active versus maybe you've got a lot of osteoporosis and you don't have stable bone, this is the expertise of your surgeon. They know which one to use on you. Their job. They're the carpenters, engineers. They know scientists that know how to get this thing in you to get the best outcome. So, you know, in the time of the internet here, you can do a lot of research to find out, hey, I like doing these things. I think I might want this type of, and then discuss it with your doctor. The other thing is you'll always see, like anything, and you'll have reps that sell that type of knee replacement, and they can be in the OR helping the doctor understand when you put their knee in, make sure you do these certain things. The doctor is the expert on how to do the cutting, but sometimes the rep tells them, hey, you know, this is the best way for this to go in. So that might be an experience. You might be surprised to hear that a guy that sells knee replacement to surgeons, he's in the room guiding the surgeon to make sure that he follows the guidelines for that. That's not uncommon. Going to the next slide. So yes, so here we go. We're going to look at what the surgery is like. So warning, if you don't like gruesome pictures of surgeons going inside knees and showing you what you're going to go through, this is time to turn your head down, and I'll keep talking and you can hear me. And then when we're out, I'll tell you when we're out, you can look back up and it'll be safe. So if you're queasy with this kind of stuff, now's the time to not look or grab the garbage pail. So please, you know, be careful. Don't, if these are going to bother you, don't look. Okay, it goes easy on the first two and then it gets crazy. Okay, so let's go to the next slide. So you're trying to figure out what's removed. So if you look on the left, you see the before picture with the cartilage worn away, and that's the mucked up bone and everything else. If you look to the right, you can see where the metal's going to go on the top part, on the femur, and on the bottom part where the tibia, the surface is going to get taken out, and then you put the bottom piece on there. So let's go to the next slide. So what happens in surgery, you're going to see, you know, of course, you're on the table all draped, getting put under, and it looks like a mechanic shop because they got a lot of tools, they got a lot of pieces that they're going to use to put into your knee. So yeah, it can look like a machine shop a little bit, but it's all sterile, of course. And the saw, there's a hammer, there's a needle and thread and a stapler for stitching and closing wounds and things. So yeah, a lot of sharp, scary objects. So go ahead to the next slide. So what you'll see when they start working on your knee, they have to position it a certain way to get different angles, because as a carpenter, engineer, scientist guy, he's got to be able to get at that properly and measure and put things at the proper angles to get a good fit. So you see these types of devices that help him to measure and position to get these things in. There's also robotic surgery where they use, you've heard of that, where it helps them with more precise cutting rather than freehand. So some surgeons are very gifted on their freehand, and others get a better result when they use the robotic. Go ahead and switch. Oh, that's fine. Yeah, next slide. So the thing to remember is this is an elective surgery. Now you can see, you know, the knee's open, fingers down in there. We are opening the knee. We're going to dislocate the patella, the kneecap, out to the side because we have to get into the joint, expose it. And then when we get the knee exposed, we go to the next slide. This is your worst one. So now they got to set things in to where they're going to get this metal in there. So the bone gets removed and they chuck that off to the side, and then they measure, get nice clean cuts, and then they figure out how to interface the metal into your body. So it becomes part of you and it becomes a functional knee. So go on to the next one. So this is a uni knee. This is only one side. Sometimes you get both sides done. Sometimes you only have one side done. And that's what this is showing. So you see they look like bent forks. Those are retractors. I always get a kick out of that. It's called a retractor. And I go, it looks like someone took a fork and bent it 90 degrees. And then what they do is they're able to pull tissue back so that they can get in there to do what they need to do. So of course, you can see after doing all these things, why your knee is going to be really sore and swollen when you come out of surgery. Remember, when you go in and you don't know this, you just wake up and your knee's a balloon and you're on the drugs, so you feel good until they start wearing off, and then you wonder why your knee hurts. So going to the next slide. So for all those that were worried, you can now look up, because it's all about puppies and kittens now. We're out of the danger zone. Everything is good and happy. So you survived. Well done. So that's what happens in surgery. So now go to the next slide. What happens after surgery? So the reason this slide is so powerful now is you see what happened on the OR table. Now you know why the knee looks like a balloon, because once you irritate that much tissue with saws and hammers and everything else, getting that thing in there, there's going to be an interesting reaction. Your body's going to be really sore and swollen from all that. So now the rehab part starts. So the surgeon's job is done. The knee's in there. You're all put up. And the other thing you might feel is you don't have any pain at all. A lot of docs are using nerve blocks. So the anesthesiologist blocks the nerve from carrying pain. So the nerve block, depending on the person, they tell you that it only lasts, so many hours after surgery, but people go, oh my God, that nerve block was, for the last 3 days, I didn't feel anything. You hear so many different stories on how the nerve block took for some people. If the nerve block takes, sometimes people come out, it feels like they had a knee scope. It wasn't as bad as a knee replacement. So it's amazing when I get those patients, and they're telling me, oh my God, my knee feels great. I'm like, wow. So if a nerve block takes, you're going to be really, really happy. If the nerve block doesn't take, and I get those patients too, it's like the old days when they never did nerve blocks. So it's a lot of pain and a lot of irritation, and you go slower, but there's nothing wrong. It's just the nerve block didn't go as well. So most of the time they go well. Once in a while they don't, but it's not a time to panic. It's just things will be a little slower because you just be more sore. Nobody likes to hear that, but it happens. Going to the next slide. So common reports after surgery, my throat hurts. That's when they put you under, they have to intubate you. So the blades on the tube, the machine or the device to get the tube in there, sometimes it scrapes your throat a little bit. So that's why your throat's sore. That's going to heal and get better. Some people feel nausea and dizziness when they sit up, and that's because some of the anesthesia that they use, that affects that. Plus you can get what they call orthostatic hypotension. Your blood pressure will drop because of the trauma you've been through. So you go to sit up and then you get really woozy. Your knee hurts when I move it and it's really stiff. You saw the pictures, now you know why. Maybe if you didn't see the pictures, you'll have to take my word for it. What they do in surgery, that's why. And then why is it so swollen? How long will it take to recover? Again, you saw what happened in surgery. If you didn't, you're using a saw, they're using hammers. So this is why it takes a while to recover. Those tissues take a fair amount of time to heal from all that. My leg's really weak and I can't lift it. If the nerve block is done really well, unfortunately, it also interrupts the signal for your brain to fire your muscles in your leg. So sometimes you'll be in a long leg brace to hold your leg straight so you don't buckle and hit the floor. And that's why your therapist is always going to be with you. They tell you don't get up on your own, because you may go to get up and then you find out your leg doesn't work because the nerve block's still active. So if that's the case, your leg isn't paralyzed, it's just temporarily not functioning while the nerve block medication runs its course and gets out of your system. So I want to go to the restroom, but I don't have the energy or the confidence to get there. And that's, your body's going to be weakened by having gone through the surgery. Plus, like I say, when you go to stand on your leg, you're not going to be sure about it. So that's why you're going to have the therapist or the nurse going with you and guiding you. Some people will have the bedside come out first, until they get the confidence and see how well they're functioning after surgery. There's no way I can go home and you feel like with how they feel right now. So you wake up and you go, oh my God, and they're telling me I'm going home today or going home tomorrow. There's just no way I can do that. There's a process to evaluate you to see about placement, which we'll talk about a little later. And then do I need a walker, cane, or wheelchair? And when you're in the hospital, they have a discharge planner and they help you with all that to figure out what do you need before you leave. So you can talk with your nurse about that and they'll help guide you with that. And then how do I shower? You have occupational therapy comes in and they discuss that with you, or depends on how long you're going to be in the hospital. Some people, it's a day surgery. For some people, they have other issues. So it may be 2 to 3 days in the hospital, and then they'll go out to skilled nursing or they can go home. So usually occupational therapy is the one that helps you with the showering, learning how to do that. Typically, you're going to have a shower chair because you're going to have a hard time with balance with standing for the first little while. And when can I walk normally is a really common question again. So going to the next slide. So I answered a few of these, but the short answer, it's going to take you about 6 to 8 months to recover fully from the knee replacement, some people a year. Remember, each month is a month of healing and recovery. So the common mistake is people think, okay, I'm going to be better at 6 to 8 months. And it's like, well, you're not totally injured and acute from surgery, and then magically at 8 months, you're fine. It's like every month that goes by, you're going to see gains and getting better. So be patient with it. It's a process. And then you're gradually going to increase your range of motion. You're going to increase your strength for getting back to running errands and things, getting out of a chair. You're going to progress from a walker to a cane and then walking free. If you were walking free before surgery, if you were on a walker before surgery, it might be more difficult. So it's like that old surgeon's jokes like, hey, doc, will I be able to play the violin after surgery? He goes, yeah, sure. He says, well, that's great because I never could play the violin before. So the thing is, if you're walking on a walker before surgery, you might be on that walker a little longer as we build the muscles back up to tolerate walking with the cane and then walking free. You have to get used to the new knee and build those muscles up to tolerate those activities. So yeah, it's something to consider there. So getting in and out of bed, going to the next one. So your knee's going to be really swollen. Go to the next slide. So when you go to get out of bed, your knees are going to want to bend. So I'm just going to show you kind of what it's going to look like over here. So if this is the knee that I had done, let's switch this around. Let's change that. If I'm lying in bed and let's say this is the knee that I had done, if I drop it off the edge and it bends, it's not going to like that very much. It's going to be really sore, but the therapist is going to be there to guide you to help support it. So what you'll want to do is as you're coming out, you'll want to bring your leg, try to keep it as straight as you can as you slide forward and then get the heel on the ground. Once you get the heel on the ground, it'll be supported. And that's what you want to do there. Okay, so that's how you get from a lying position to a seated position. We're going to cover a lot of little things. It's just to put give you initial information to let you know how it's going to be. So when you go to get out of bed, your knee just isn't going to bend exactly how you want it to. So you're going to have to kind of guide it through. And that's what the therapist is there for. They're going to help you get through that getting out for the first time. So that's how that looks. And then getting off of a chair and in and out of a toilet, it'll look like this. So you'll have the walker. And if this is the knee that's replaced, you may not be able to do this to get up. So you'll bring that leg forward, one hand on the walker, one hand on the chair. Then you help yourself stand up, and then you get yourself to here, and then you start walking from there. So it's just when your knee's really sore and swollen, you're kind of wondering, well, how do I get up? And that's how they get up, and they do really well. And once you do it once, then your confidence goes up really fast. Like, oh, I can do this. It's like, yeah, you'll be fine. So yeah, going to the next slide. That was what I was showing you there. That's how you get up there. You keep that leg forward, and because your knee may not be able to tolerate bending that much so soon after surgery. And then getting in and out of the car, going to the next one. It's just really similar. What you might have to do is you might have to get in the back seat when you're trying to go home, and you have to scoot yourself back because your knee may not be able to bend far enough to get in the passenger side. So you have to consider, you know, what's your travel plans for when you go from the hospital back home. So you want to have a car big enough to where you can get yourself in and out. Very good. Going to the next surgery. So, or the next surgery, go to the next slide. Can I walk after surgery? So you will be getting up the same day of surgery or the next day, depending on the time of your surgery, your comorbidities, what's going on with you, you know, heart conditions and other things that may be slowing your recovery, and then how you respond to anesthesia. Some people get really woozy for a day and they have trouble getting up after that. And then how you respond to narcotics, because they're going to be giving you narcotics for pain control because they had to saw the bone. So yeah, you're going to need strong pain relievers to manage that after the nerve block wears off. So, and then not for very long. it varies person to person, but some people get to Tylenol actually fairly quickly within a couple of weeks, and other people are on the opiates for a little longer. So you just want to have good guidance with your doctor there. You may have a long leg brace on. Remember, your knee will buckle when you stand. That's from the nerve block because the muscle may not be working at 100%. That'll resolve and come back. You'll be using a walker for stability to prevent falls to start. And then as your muscle starts working a little bit better, your balance starts coming back, you transition to cane, and then you go to walking free. On your first walk, you want to be aware of, are you dizzy, lightheaded, or nauseous? Sometimes with the drugs you're taking and the anesthesia, if you feel at all when you're with the therapist, I always ask 100 times, are you woozy? Do you feel lightheaded? A couple of my experiences as a younger therapist is I was shocked at the amount of time for, hey, I feel lightheaded, and then the person was already fainting. So a lot of times I'll keep the patient next to the bed and I'm watching them to see, if they get sweaty and they get a little funny in the eyes and they're like, oh, yep, they're pretty lightheaded. So they need to sit back down on the bed because we don't want to have a fall on the floor. So you got to have good communication when you're talking with the nurses and your therapist. And then are you sweating or feel severe fatigue? Sometimes an aggressive sweating and you feel really tired, that's a warning that your legs might buckle or something like that. So remember, however far you walk away from the bed or walk away from something, you have to get back. So you want to make sure you have the ability to do that. So you'll naturally want to walk like a pirate who is in a wedding. What that means is when you're walking, again, this is the knee that's injured, you'll take a really big step with it because when it's in the air and swinging, there's no weight on it, so it doesn't hurt. As soon as you transfer weight on it, you don't want to be there very much, so then the other leg comes through pretty quick. So you're like that. So, when you're watching those movies where someone's walking in a wedding, they take one step and then they step to their foot and then they take another step and they step to their foot. So that's what I call it. You're walking like a pirate because you got a peg leg because you don't bend your knee, and then you do that type of a step. So what we want to do very quickly is we want to try to eliminate that habit, because after you start learning to walk like that, then you keep walking like that, and you want to avoid that. Okay. So you don't want to try to unlearn it later. So don't rush it, take it one day at a time. So what exercises are you going to be doing after surgery? So quad sets, heel slides, short arc quads, and straight leg raise. So we'll just kind of blast through these. Again, we're not, if you guys want to join in, if you're able to get on and off the floor easily, if you're doing it in bed or off a couch, that's fine too. If not, just watch and you can see what these are. So what the quad set is, the first thing you want to do is you got to get your knee as straight as you can, as soon as you can. So what you'll start doing is you'll get a rolled up towel, you'll stick that under your ankle. You need a cameraman. And what that does is it gives you space here. So you're going to squeeze your quadricep muscle and you're going to push your knee flat into the bed. And you want to see your quadricep muscle actually contract. What some people do is they cheat. They just use their hip and they push their leg into the bed, but they're not using their quad and trying to straighten the knee. So you see how there's a space there and I get rid of that space? You've got to get that knee straight, straight, straight. If you don't get the knee straight, a bent knee is a short leg, right? So if you're standing up and one leg is straight and the other's bent, right? See how my belt line drops? That's a shorter leg. And then you start walking around like this. And if you walk like that, that's going to get your hip and your back. So don't do that. So the next one you're going to do is heel slides. So you use a towel, or if you got a sock on the sheet. So what you do is you bend the knee until it feels tight. Then you pause. Don't let it drop. Bend it again. Bend it again. Bend it again. And what will happen is you'll feel where the end is, where it won't go anymore. because it's too painful and too tight. Then you go back down. The mistake people make on this one is they stop short of that end and they just go up and down where it feels good. You've got to try to find the end to try to help increase the range more and more and more. Very good. So that's a heel slide. Then you'll do the short arc quad. So you get a foam roll, it's about a 6-inch diameter, or you get a couple of towels and roll them up. And then what you do is you straighten the knee, lower the knee, straighten the knee, lower the knee, helping to build that quad and get a nice straight leg. Good. And then the other one you want to do, which is harder, this knee's bent for your back. Like the first quad set, you push the leg flat, you lift the leg up, lower it down, and release. Push it flat, lift it up, lower down, and release. And that'll help to build your leg up for the straightening the leg as well. So we can go to the next slide. And that's see the bent knee? Some people are off the mat that far. You got to get that straight. Don't put pillows underneath. It's going to feel good, but you're going to hurt yourself and you're going to get scarred. And that's called a knee flexion contracture. Then I got to lean on your leg. That's when people hate their therapists, and I got to hurt you to help you. I got to get your knees straight fast before that scar tissue becomes permanent. If you have a bent knee, you got a short leg, and then that's going to affect other things. Going to the next slide. Next slide, please. So there's the quad sets. We just kind of we blasted through those. And then we'll go to the next slide. Yep, there's the quad set with the towel. And again, next slide. So the heel slides, we'll go to the next slide. Well, I just went through these. So that's the bending of the knee that I did, sliding on the towel. And then the next slide, short arc quad, and the next slide, that's over the roll. Just wanted to save some time here. They're kind of self-explanatory once you see them. Picture's worth 1,000 words, right? And then to the next one, the straight leg raise just has it described, and then that's it there. Perfect. And then walking. So some of the techniques that'll help you, you perform interval training. So you'll notice you can't just walk 30 minutes. You'll want to, but you won't be able to last. So when you do interval training, you have a less risk for flare-up. What a flare-up is your head writes checks that your knee can't cash. So you go too far and then your knee gets worse swelling and it hurts and you can't do as much. So you walk 1 minute, rest 1 minute in a seated position. You unload your knee. If you do 10 1-minute walks with a 1 minute rest, it's going to take you 19 minutes, but you get a 1 minute rest after each thing. All of a sudden, that's going to become too easy. So then you increase the walk interval to 2 minutes, 3 minutes, 5 minutes. And then if you did 6 5-minute walks, it's just simple math. Now you're doing 30 minutes of walking time, but you're only doing it in 5-minute increments so you don't flare up the knee. So you don't want to go from 0 to hero. You got to just gradually build it up over time. So depending on what type of walking you perform, hours of walking versus minutes of walking, you just set your goals based on that. Very good. Go to the next slide. So what exercises do I do before surgery? You want to perform the same exercises that you're going to perform after surgery. So the ones I just showed you, the quad sets, the straight leg raise, the heel slide, and the short arc quad, you want to do all those because you're going to develop the muscle memory because they're not going to be new. You know how to do them. So your body remembers. So once you do that a few times, then when after surgery, you go, oh, I already know these, it's not a surprise, and then your body will react faster. You want to progress your walking intervals to tolerance because now you've got your osteoarthritic knee. You don't have your new knee yet. So walking may not be something you can tolerate, like the interval training. So the pool is great for that because you're buoyant in the water, it unloads your joints, you can go longer. So try pool exercises there rather than the interval walking if you can't tolerate it. And then there's a number of hip exercises you should be doing because a strong hip helps you to control the knee. And we'll go through those next. So the hip exercises, next slide, are the clamshells. Going to the next slide. clamshells, the hip abduction, the monster walk, and the mule kicks. So we'll go into the next slide. So the clamshells, you may have seen this one. This is a Pilates exercise. Is you go lying on your side, you keep the feet together, knees together, you lift the top knee up and then down. And where you'll feel it is you'll feel it in the buttock right here. Okay. Now, if you to make it easier, you roll your pelvis back. To make it harder, you roll your pelvis forward. And then there's more load. You will notice I can't lift as high when I roll forward because it's harder. That's clamshells. Hip abduct and kick your leg out like this. You want to get a straight line from your shoulder to your hip, to your knee, to your ankle. You got to keep the pelvis forward. This is wrong. So you see how I'm lifting my leg up and forward? That's no good. You've got to get the pelvis forward, get that nice straight line, and go up and back. And where you'll feel it is right there, right on the buttock. And that's the muscle you need for balancing. So that's why that one's important. The monster walk is you take a TheraBand, that rubber stretchy band or tubing, and you wrap it around your legs above your knees, and then you sidestep. So we'll just have to imagine I've got a band around my legs, and you step to the side, fighting through the band. So when you see the picture of the fella there, you see how the band's above his knees, and then he's walking sideways, and that builds that butt muscle as well. And then mule kicks, that's the one where you're up against the bed, most likely. And you might have to lean on something here, and then you kick up this way. And you'll feel that in the glute. Stronger the hip, the easier the knee to do its job to do what it does. Going to the next slide. So placement after total knee replacement. Do you live at home? What kind of support system do you have? Do you live alone? Do you have family? Do you have supportive friends? Do you have a caregiver? What's your home like? Are there stairs? Is there an elevator? How far is your bathroom from the bed? What is your tub or shower like? Can you walk in? Is there room for a shower chair? These are the things you have to want to evaluate before. Is how are you going to get in and out of the shower? If you can't stand, you need to sit so you don't fall. And then is it set up to where you can shower and not get water all over the place, and so on and so forth? Do you need a caregiver? Are you able to do this yourself or not? If you're in the hospital and you cannot walk, here's a good guideline. If you're in the hospital, you can't walk from the bed to the bathroom and back without feeling dizzy or feeling like you're going to fall, then you need to be in either skilled nursing or acute rehab to regain your strength to function at home. So if you want a benchmark for when you can go home, imagine if someone takes you home, you can walk from the car into the house, and then you're exhausted. You get to your bed, you can't get from the bed to the bathroom. You know what's going to happen. So use the hospital as the test. If you can't get from the hospital bed to the bathroom and back on your own, then you don't want to go home, because you're just going to be right back to a skilled nursing facility or acute rehab. So yeah, and you don't want to have a fall. So that's a good guideline. Skilled nursing or acute rehab after surgery. Right. So the whole thing about if you can't walk to the bed to the bathroom and back. So why would you go to skilled nursing? They have a staff to keep your room clean and feed you. There is help with personal hygiene and toileting to prevent falls. They have a rehab staff to help you gain strength and function so you can return home with decreased risk for falls. So you do have to do some shopping though. You got to find out if the skilled nursing facility has everything you need for total knee replacement. Some are set up for it, some are not. So you don't want to get stuck in a place, do some work before you find out if you need to be placed in skilled nursing, where would you go? You got to find the place first before, yeah. You know what I'm saying? Know where they're going to send you. Yeah. All right. So home health after surgery, if you can walk from the bed to the bathroom and back without feeling dizzy or feeling like you're going to fall, and then you'll do well with home health. So what will you need? You'll need a walker and a cane as you progress to independent ambulation. You'll need raised toilet seats to make the toilet seat transfers easier, because if the seat's too low, your knee doesn't bend that far in the beginning. A shower chair to help you with showering, and a shower with an extended spray handle. So you know the one you kind of pull it off and you can spray yourself down. You'll need that. And you'll want to regimen yourself to get up for meals, interval walk during the day, and perform your exercises. Because if you are at skilled nursing, they get you up for breakfast, lunch, and dinner. You get 2 exercise sessions per day, and they just keep you moving. So that's how you get better faster from total knee replacement. You don't lie in bed with a pillow underneath your knee. Don't do that. You'll regret it. Yeah. So outpatient physical therapy, then what'll happen is, depending on how you perform after surgery, it'll tell you how fast you'll be able to refer to outpatient. Why? Even after a month, you'll be swollen, stiff, and weak. So you'll be able, you'll be an outpatient for approximately 2 months. And you'll be working on correcting your gait pattern, gaining more range of motion and strength. You'll be working on balance and functional activities specific to your movement. And then when we start getting really good near the end, we grab the hiking poles and then do a short distance up and incline, just to start testing out the knee for higher level function. So when we're at outpatient, we try to take you further than just home ambulation, if that's a goal. And then how long does it take to fully recover? Again, it takes about 6 to 8 months. Remember, every month that goes by is a month of healing. It gets better, feels horrible in the beginning. The first 3 months, you're wondering, why did I do this? And then after 3 months, you're going, I know why I did this. I feel a whole lot better. You'll recover more efficiently if you stop putting pillows underneath your knee. Get a straight knee as fast as you can. Then you'll buy rehab time on the end. You get better faster. Do your exercises. Your outcome is only as good as how you perform your daily routine. If you don't exercise, you're going to get a stiff, stuck knee. You're going to start blaming your surgeon. You're going to blame your therapist and everybody else. And I found that those patients just need to look in the mirror. You got to get your work done. If you don't get the work done, you're not going to get a good outcome. So we want to work with you. You work with us. Let's try to get you as good as you can be. Okay. So don't kneel on your knee. Sometimes the doctors tell you can. My experience, every patient I've had that kneels on their total knee, it just hurts. Why? Because right under that skin now is metal. So it just pinches. I tell all my Catholic patients, with respect, God understands. If you don't kneel on the knee, it's okay. So, just be careful. Don't injure your knee. You bought a wonderful knee. You bought an, life to get moving. And if it bothers you, don't kneel on it. Use the walking aid to prevent falls until your strength and balance are adequate. Some of my patients try to jump through to the cane to walk it free too fast. They get a knee buckle and they fall. It happens gradually. Don't write checks your body can't cash. You can't go from 0 to hero in 2 weeks. So you got to go gradual. So now, next slide. You are now knee experts. Yes. So hopefully the information was helpful. Hopefully, does it help you to plan? So give you a lot of angles there to know what to expect and how to get ready for it. Think about the timing of your surgery and life events. If you've got a travel plan, a wedding to go to, you got an Africa trip that you've done set, and you got to do a safari in those Jeeps that go over all that bumpy ground. Make sure that you plan your surgery and recovery so that your knee's ready for that kind of stuff. Yes, there's pain when with this recovery, but when they're we're there to guide you and help you learn what to do, okay, to get through it all. You're going to have flare-ups. You're going to work out, your knee's going to flare up, and that's going to feel better. And that's going to flare up as you keep challenging it. But overall, it just keeps getting better month to month. So not all people are zero pain after surgery, so consider this before you make your decision. Remember some of the stories I've told you. Some people jump to their surgery too soon, and it seems that that was a factor for them. It seems the ones that are really in trouble, that the knee's really hurting, those are the ones that do better. And the ones that do the exercise to get their knees ready, those ones do better as well. So, but some people do get pain from hardware. Some people do have residual pain for reasons unknown. So we know that they exist. So, most of them do well. Sometimes you just don't know how you're going to turn out. Ask other people who have had the surgery and what experience there was like. You're going to get a lot of variation across the board. Watch how they walk. If they walk with a bent knee, I'll bet you they tell you they hated the knee replacement. Remember, you got to get it straight. And then after the years that I've done this, I can say that doing the right thing at the right time for the right reason usually gives you the best outcomes. And doing your exercises. So thanks for listening. Thanks for coming out tonight. If you got any questions, I'd be happy to answer them.